I'm going to talk about non-liver and survival benefits after SVR in mono and co-infected. Where I have co-infected data, I will show it. Where I don't, I will show the mono-infected. So you know from yesterday that hepatitis C deaths are increasing while other notifiable infectious diseases are decreasing, including HIV, TB, and hepatitis B. So this is an ongoing problem, which is kind of scary after we heard the symposium just finished, where we're trying to eradicate hepatitis C. We have a little ways to go. And this slide, I think you've seen, looking at all-cause mortality benefits in patients who've achieved a cure. And on the left, you can see this is 5 large hepatology units in Europe and Canada of patients with advanced fibrosis, and they're compared to an age, sex, and calendar year match control from the Netherlands. The median follow-up was over 8 years. There were 192 patients who had SVR, and compared to 405 who did not. And on the left, you can see that having an SVR means that your survival is the same as the general population, whereas on the right, without an SVR, you can see the marked diminution in survival. This is one of many studies. We heard from Dr. Agarwal yesterday that at King's College, there's a marked decrease in hepatitis C patients coming to transplant. This is data from the US, from Nora Turo's group, showing the reduction in transplant listing for hepatitis C since the DAA era. So overall, you can see there's a decrease in hepatitis C without any change in B, and an increase in fatty liver, which is the new disease that's going to take over the world. In the middle is decompensated cirrhosis, which in the DAA era is decreasing, but cancer continues to be a problem and will keep being a problem for the next 2 or 3 decades at the moment. This is data from Andrew Hill, who did a meta-analysis of 129 studies, over 30,000 patients, and looking at the effect of SVR on survival of hepatocellular carcinoma. So on the left is the 5-year risk of death, all-cause mortality, and this is in all the patients. You can see having an SVR is half the death rate compared to the patients who had no SVR. This is even more startling in cirrhotic patients, where it's nearly 3 times if you don't have an SVR, and in co-infected patients, even higher. And on the right is the risk of cancer, and you see similar data, no SVRs in red, 3 times higher cancer than those in the general population, much higher in cirrhotics, and higher in co-infected. But I bring your attention to the fact that there is incidence of cancer in patients who get SVR. So you can't get rid of those patients from your clinic, and you can't use FibroScan to say they don't have cirrhosis anymore. So there are many recognized benefits of HCV cure: reduction in mortality, reversal of decompensation, reduction in hepatocellular carcinoma, reversal of fibrosis or cirrhosis, reducing the risk of transmission of HCV to others, and the real question is, what about extrahepatic manifestations? Well, this is a slide from Nora Turo, which is data from the IDSA-AASLD guidelines, with the multitude of extrahepatic manifestations, including hematologic, dermatologic, renal, endocrine, ocular, cardiovascular, neuromuscular, autoimmune, and psychiatric. And I'm going to pick I can't do all of them, but I'm going to pick a number of the big ones to really discuss one by one. So let's start with cryoglobulinemia, which is common. Asymptomatic cryoglobulinemia is common in about 50 to 60% of patients if you look for it, but symptomatic cryoglobulinemia is rare, around about 5%. So this is a study from 18 symptomatic and 65 asymptomatic patients, 10 of whom who had severe life-threatening vasculitis. 80% received interferon-free DAA therapy. 90% had an SVR in both the symptomatic and asymptomatic patients. Cryoglobulins disappeared in about 30% of the symptomatic, but a higher percent of the asymptomatic patients. And if you looked at the symptomatic patients, clinical response was complete in 38%, partial, which means a 50% reduction in cryocrit in half of them, and complete in about 40% and partial response in 22%. And of the patients who had severe vasculitis, 7 of them, 6 achieved an SVR, 1 had a complete response, 3 had partial, and 2 had no improvement, which is unfortunate. All 4 patients with life-threatening vasculitis required subsequent plasmapheresis, and 3 of them received rituximab, even though all of them achieved an SVR. So I think that's the caution, that you can get an SVR, but you may not reverse vasculitis. The most common reversal was that reduction in skin manifestations in 39%. Only 11% had reduction in renal disease. But 2 of the patients who were on hemodialysis actually got off hemodialysis when they got an SVR. So even if they don't end up with normal, these were very stringent requirements. They had to have no proteinuria, normal creatinine, no sediment in the urine. So I think looking at a partial response may have been a lot better, but they improved their GFR. And only 11% had reduction in neurologic symptoms. All but 1 patient completed therapy. There were 19 adverse events, including 5 hospitalizations for decompensated liver disease during treatment, and 4 for and this is interferon-free treatment, and 4 for worsening vasculitis. So here's a picture of the cryoglobulins. You can see the symptomatic patients start with a higher cryocrit, so it's not surprising it takes longer to come down. And the asymptomatic had a lower cryocrit, which is why it came down more quickly. What about lymphoma? I'm going to show you 2 studies. This study from last year of 61 patients receiving PEG interferon and 10 receiving DAAs, and they compared them to 94 matched HCV controls who didn't have non-Hodgkin's lymphoma. The lymphoma was 38% large, diffuse large B cell, and 11% marginal zone. And they looked at the non-Hodgkin's lymphoma B cell response, and 69% had a response when they had an SVR. 30 was complete, and that means no evidence of lymphoma. 12 was partial, which means at least a 50% decrease in measurable size of lymphoma. And this was compared to 31% of patients who had a lymphoma response without an SVR. And this is 90% response to DAAs. This was followed by a very nice paper, which was a meta-analysis of 20 studies, including 254 patients with HCV non-Hodgkin's lymphoma. And they had, with HCV therapy, 73% had an overall lymphoma response. So that's what I'm talking about, not Hep C response. In those who had an SVR with DAAs, 83% of them had a lymphoma response, compared to 53% in the non-SVR. So this data is different from the last paper, but still statistically significantly different. There was an 81% favorable response in marginal zone lymphoma, which was a little better, but didn't reach statistical significance in the non-marginal zone. And this led the authors to conclude that antiviral therapy should be first-line treatment in patients who don't meet the immediate need for conventional treatment for non-Hodgkin's lymphoma. There was a strong correlation of SVR and lymphoma regression or even cure, supporting the causal relationship between HCV and lymphoma, non-Hodgkin's lymphoma. So what about other outcomes? We talked earlier about cardiovascular. Remember the Brazilian study that had a very high cardiovascular and renal disease. I don't quite remember how much diabetes they had, but maybe we can talk about that later. And this is a study by Sue who looked at 5,600 diabetics who didn't have Hep C and compared them to 1,400 Hep C patients who were treated and 1,400 who were not treated. So on the left, this is the cumulative incidence over 8 years of end-stage liver disease. So in red, you can see untreated Hep C had a much higher incidence of end-stage renal disease, oops, I've lost it, compared in blue to the diabetic patients without renal disease. And remarkably, patients on the bottom in black, these are the patients who were treated who had Hep C and diabetes, marked decrease in the incidence of end-stage renal. On the right is the incidence of ischemic stroke in the same cohort, and you can see there was no difference between the incidence in diabetic patients without Hep C compared to those who were untreated, but the treated patient had a marked decrease in the incidence of ischemic stroke. And the hazard ratio showed that for end-stage renal disease, curing hepatitis C decreased the incidence by over 80%, by 50% for ischemic stroke, and by 30% for acute coronary syndrome. So a remarkable paper showing the benefit of getting rid of generalized inflammation associated with hepatitis C. And another study from UNUSI looked at mental and physical function. This is 624 patients, of whom 618 had SVR. And you can look at the top marker, which is the quality of life, and the next one is activity and energy levels. And what's remarkable is you see an increase as early as 4 weeks, and this continues even after the end of treatment. This is the physical, again looking at the physical component of the SF-36 questionnaire and the mental component, again showing an increase over placebo in patients who were treated and achieved SVR. But it's not all rosy. This is a little hidden paper that came out last month from Marina Klein's group in Canada. Of the over 1,000 co-infected patients, they had 223 with a health questionnaire. They had 86 that were treated and achieved SVR and 68 who did not. And SVR was associated, as I showed you in the last slide, with improved quality of life scores over time, with a lower rate of healthcare utilization, which I think is really important when we're talking to our government agencies, the extrahepatic benefits getting people back to work are really quite profound. There was a suggestion that perhaps short-term mortality was improved, but it wasn't significant. However, after SVR, they found that their patients had increase in alcohol consumption and continued injection drug use. So whether that will end up with liver disease of a different sort is a different question. This is a study from the HCV cohort from Dr. Beringer from 5 years ago of nearly 1,600 patients, a third of whom had SVR, followed for 5 years. And they showed lower mortality in patients with SVR compared to non-SVR overall, and lower liver-related death, as we expect. But they also showed in the patients who failed to get an SVR that they had higher rates of AIDS-defining conditions with a hazard ratio of 1.9, higher rates of non-liver-related deaths with a hazard ratio of 3.19, and higher rates of non-liver, non-AIDS-related deaths with a hazard ratio of 2.85. So here's that data. Here on the left is non-liver-related death is increased in patients who didn't achieve SVR, and mortality is lower for non-liver, non-HIV-related deaths on the right. So they followed up with a paper that is online but not yet published, with a similar cohort, a few more patients, looking in co-infected patients. Remember, I showed you the diabetes and end-stage renal disease in HCV patients, and this is in co-infected patients, and showed the same, as I showed you before, a significant decrease in the incidence of diabetes and a decline in chronic renal failure. So there are many recognized benefits of HCV cure: reversal of fibrosis, reversal of cirrhosis, reversal of decompensation, HCC mortality, and less need for transplant. But I think we have to really consider and look for the other benefits of HCV cure, which is lower rates of extrahepatic complications, decreased cryoglobulinemia. Unfortunately, the data so far shows that the skin manifestations appear much higher rate of decrease compared to the more serious manifestations of vasculitis, such as renal disease or CNS disease. I didn't talk about porphyria cutaneata because that was discussed earlier in a poster. There has been one paper looking at it showing improvement in skin lesions, such as was seen in this publication presented today. There's also reduction in co-infected patients in diabetes that's been shown in monoinfection too, reduction in renal disease, and remember that the renal disease was really quite a stringent look. But if you look at the benefit in terms of improved GFR, it's quite profound. Better non-Hodgkin's lymphoma response, in some patients even a complete response, and a partial response in others. Reduced mortality not related to liver disease. And I think very interesting is reduction in HIV progression, which is hard to tease out, so you need quite a large cohort to be able to do that. And finally, improved quality of life and work productivity. So in summary, there are many benefits of HCV cure that are both liver and non-liver related, but remember, concurrent alcohol or fatty liver places patients at risk for future cirrhosis. So if patients have comorbidities, don't send them away from your clinic because they will need to be monitored for fibrosis progression and for development of non-HCV liver disease. Remember, all cirrhotics need HCV monitoring even after SVR. You need to counsel healthy liver practices. When patients are cured of their HCV, it may not be ideal to develop alcoholism and continue to use drugs. And monitor for reinfection in all high-risk patients. Thank you.